So we'll go ahead and start off with the first question, which an important question to ask your endometriosis surgeon or the person you're seeing for your endometriosis is endometriosis your primary specialty? Folks who are well-versed in excision and who are experts in excision, this is going to be the vast majority, if not almost exclusively, the patient population that they see. It's very difficult to become an expert in excision and maintain the skills that are necessary to do high level and high quality work if attention is directed elsewhere. For example, taking care of pregnant patients. Obviously, that is something that is very important to do as well. Pregnant patients need care as well, but it can be very, very difficult to maintain expert level skills to do the quality of excision surgery that's necessary to get patients excellent outcomes. And so, again, an endometriosis surgeon's practice should be primarily focused on the management, in particular, the surgical management of endometriosis. That should be the primary bulk of the patient population that they see. Okay, the next and one of the very key questions to ask the endometriosis surgeon is, do you ablate or burn the endometriosis, or do you excise? Time and time again, excision has really been proven to be the gold standard in surgical treatment for endometriosis. Just to share with you a few reasons why that's the case. Number one, you have to have a specimen to diagnose endometriosis. And by definition, burning it will destroy the specimen. So there's absolutely nothing for the pathologist to look at. Even in expert hands, we're only right maybe 60, 80% of the time about what we visually see and call endometriosis actually being endometriosis. So 20%, that's a pretty big percentage to be wrong. And in the hands of folks who do not perform this surgery very frequently, they're only correct 40% of the time. So it's kind of the flip of a coin. And so with excision, you have a specimen that can be looked at by the pathologist. Number two, with excision, you're able to have a margin around the specimen. And it's very important to make sure that you're removing the endometriosis and that you know where normal tissue is. With ablation and burning, it's very difficult to know where the abnormal tissue or the endometriosis stops and the normal tissue begins. Number three, there's a concept in surgery of something called thermal spread. So when you are doing the burning, there could be very important structures nearby, and the energy from the instrument used to do the ablation or burning could travel and get to those organs and burn them and hurt them. And a lot of these injuries tend to have a delayed presentation, so you might not recognize it immediately. The next important question is, it's very important to understand how many surgeries your endometriosis surgeon does, how many endometriosis surgeries your endometriosis surgeon does. It might be easier to ask this question in the form of, how many do you do per week? How many do you typically do in a month? A good surrogate marker, you might want to ask your surgeon, how many days of the week are you in the operating room? So these are all important questions to understand the volume and exposure that your potential surgeon has to endometriosis surgery. The next question is, how many complex surgeries do you do per year, per week, per month? We know endometriosis is a systemic disease, and up until relatively recently, the only organ that endometriosis had not been reported to be found in was the spleen. But lo and behold, they found it and reported it being present in the spleen. So it's important to seek a surgeon that has experience with or access to a team that can assist with taking endometriosis from the bowel, from the bladder, from the ureter, from the diaphragm. And it's important to ask the questions about the resources that the endometriosis surgeon has available within their realm and within the community in which they practice. The next question is, what are your complication rates? And I will preface this by saying that it can be difficult to truly know what your complication rate is. What usually happens is a patient has surgery. In my practice, I see the patient about 1 to 2 weeks after surgery, where we'll check in. We will go over the pathology. We'll go over the operative report. We'll go over pictures that were taken at the time of surgery. And typically at that point, the patient would be discharged from the clinic, for lack of a better term, unless there's something that we need to have ongoing follow-up for. That being said, sometimes patients have complications and surgeons never know that they have a complication because they traveled from far away and they went to a hospital near their home, and sometimes that hospital doesn't notify us. So that can be a difficult question to quantify, but it is important to ask the question. You might want to ask what types of complications have occurred and see if the surgeon can answer that question for you. We typically say in surgery that if you're not having complications, you're probably not doing enough of the cases. The only surgeons that don't have complications are surgeons that don't operate. So it is an inevitability. That's why we discuss and have an informed consent process so that you as the patient understand what is possible. The next question is there any case where you wouldn't remove endometriosis? The answer to this is it's important to individualize the answer. It depends on the organ where it's located. It depends on the skill level of the surgeon. It also depends on the resources that the surgeon has available to them. So this is going to be on a case-by-case basis. This is going to be on a surgeon-by-surgeon basis, but a very important question to ask. We're always asking ourselves as surgeons during surgery, do the risks of what I'm doing outweigh the benefits? Typically, if the answer is yes, then it would not be advised to do that at the time of surgery. But if the opposite is true, and it seems like there would be a lot of benefit relative to the risk, then it would make sense to move forward with that next step of the surgery or removing the endometriosis from that organ. I would also say with the caveat that the patient has had the risks, of course, discussed with them, and they agree to that. The next question is, what areas of the body do you check? Clearly, most fellowship-trained gynecologic surgeons are very, very comfortable checking in the areas of the pelvis. It's also important to look in the upper abdomen. You want to be looking at the liver edge, the gallbladder if it's still there, of course, the diaphragm, and checking the appendix as well, looking at the bowel too. Okay, all of these areas could potentially be involved, so it's very important to do a thorough survey of these. Sometimes patients ask about whether or not the sciatic nerve or various nerve structures are accessible. In your standard diagnostic laparoscopy, looking at the sciatic nerve or the sciatic nerve root is a very complicated high-risk dissection, and so it's typically not a part of your standard diagnostic laparoscopy. The next question is, will you take tissue for biopsy? And this goes back to the question about, does the surgeon do excision or ablation? Excision, by definition, is an excisional biopsy. So it is both a biopsy and it is a removal of that affected area.